Afternoon. Let's kick this session off. This is a sponsored session from Meril, Aligned for the Future with Myval THV, transcatheter heart valve series, and complex PCI solutions. These are my conflicts. So what we'll do in the next 45 minutes or so is to discover the next generation complex PCI toolkit, a couple of really interesting things with thin-strut platforms and dedicated stenting solutions. For example, bifurcation, stents and long stents and tapered stents. But also to learn about the Myval THV series, the key features, procedural and clinical benefits, and a quick update on the recent clinical data of the Myval series from Landmark RCT and Compare TAVI trials. This will be a quick succession of talks. We've got discussions here. My name is Andreas Baumbach from London. I'm with Khaled Al-Shaibi from Saudi Arabia. Discussants are Goran Stankovic, Hussam Noor, Mirvad Alasnak, and Mariam Mirpuya, who has just arrived. Hey, welcome. So the speakers will come up and deliver their talks on this podium, and I invite the first speaker to do exactly that.
Jared.
We do have Javad Kojuri. There he is. Large real-world case series with thin-strut DES platform. Good. Yeah.
Dear chairpersons, ladies and gentlemen, this is my pleasure to present a large real-world case series for Evermind 50 stent, and I don't have conflict except Honorio. What do you want from a stent, and what is the best stent in the world to start with? A stent should be flexible with good coverage and good radial force, good passage to be simply inserted in the place. And this stent should give you proper side branch access if you have a bifurcation. And in future, in the follow-up for the patient should have enough endothelial growth, not too much, not too low, to let the vessel to be re-endothelialized with enough coverage of the stent without loss of the endothelialization at all. These factors, these 5 factors, can be met with the stent design. And this stent design is a stent platform, and a strut thickness is very important. As you know, metal which remain there in the coronaries is the crucial, important thing in the acute results and in the follow-up as the MACE results of your patient. And Evermind 50 have a thinnest struts of stents around the world. So, ladies and gentlemen, we are talking about the thinnest strut stent around the world. And I will discuss later this platform of this. Enough endothelial growth and good stent follow-up will be met by using good polymers, degradable polymers, and use of good drug to let proper endothelialization of the stent. And this is important to be in mind. So Evermind 50, which we are using for a while in our cath labs, has a thinnest strut around the world, biodegradable polymer, and drug-eluting stent, which is what you want. This is the all criterias which make an elegant stent to be considered for routine practice. Let's rehearse your mind. This is a case, as you see here, very bad bend in LAD, almost parallel LAD with large diagonal and a very large septal coming just at this area. And we can hardly rewire the LAD with a dual lumen micro and use of hydrophilic wires. And as you see, very hardly we can wire this. And this is the result with putting two biodegradable polymer Evermind 50. And as you see, using the thinnest strut stent in the world cause excellent vessel comfortability. And this stent comfortability can give to this side branch to be remain there. And as you see, this is one or two struts just pushing to diagonal branch and without any impinging that. And with this flexible stent, you can easily pass through this very complex anatomy. So this is a comparison of different stents from different generation, and we are talking about the fourth generation of the stents. This stent has a hybrid design, and I will going to discuss this hybrid design in just a few minutes. This stent is cobalt chromium, and the thinnest strut, as you compare this stent with the prior stent, you see that Evermind 50 have a 15 micron strut thickness, and remaining metals there are the least, with just 1.25 micron of the drug there. This thinnest strut give this clinical scenario and make it easily to be put your stent in the place in complex situation, because the stent is very flexible and easily can be delivered in a very complex situation. But in the future, because there are less metal there are less turbulence and less endothelial injury, and this on the paper will go to the better result of the clinical outcome in this. And this is another case. As you see, this is a quadrifurcation of LAD. Three diagonal, two small, and one very large diagonal here, and very bad bend of LAD here. As you see, this is a kind of quadrifurcation of this lesion. And we put three wires, just protect one of these small and these two large diagonal, and do decay crash for these two large diagonal and LAD, and this is the result. As you see, using the thinnest strut with good side branch access, make these two small diagonal to remain there even after decay crash, and this is the excellent result and showing the stent in the clinical scenario. The important thing in this stent is, in spite of having the lowest thickness of stent struts, due to chromium cobalt, the patient has a good visibility in fluoroscopy. And the other important thing is its hybrid platform. The stent is open cell in the middle and closed cell in the edge. So this will guarantee the excellent passage and flexibility with good coverage and increasing the radial strength of your stent. And this, all of this make one of the best stent in the world. And this hybrid platform cause, when you compare it head to head with Xience, you will see this is 13% better pushability and 24% less track force for this. And this is another case. This is a case of CTO with bridging collaterals. And as you see, this is the second try of PCO in this case. The first try was failed and end with perforation at this point. And this is a new angio 2 months after this. And you see, after using Gaia wires and passage to through the CTO and covering this large PDA here, we put two Evermind stent. And as you see, this is very good clinical acute results. There are many studies from the large clinical trials and registries from Evermind, and this is one of those which recently illustrated, and this is a 24-month follow-up of patient on Evermind, and as you see, there is excellent acute result, no stent failure, with excellent luminal area in acute. But in chronic, as you see, there is at least lumen loss in this case, and MACE is 2.4, which is among the best stents in the world. And this long-term result reached to this point that this stent is good comfortability from the vessels with good MACE results. Sort out 12 is another registry. This is Danish-based study, and following the patients, more than 3,000 patients for 5 years, and the result will be ready in just near future, and let more light to this stent and its excellent results. So, ladies and gentlemen, we are talking about the thinnest strut stents with best platform design and best drug, and the biodegradable polymer, which, in my opinion, could be one of the best stents in the world. Thank you for your attention.
Thank you very much. I think in the interest of time, we move on. Mervat, could I ask you to come on and discuss managing bifurcation lesions with a dedicated side branch stent?
Well, good afternoon, everybody. I was tasked to discuss bifurcation lesions, managing them with dedicated stents. I think those of us who've been around for over a decade know that we've been trying to explore this technology as a community and haven't really gotten there yet. And there are challenges to treating bifurcations, and that's why they are particularly unique. One is a technical challenge because you don't want to be compromising the side branch. You don't want abrupt vessel closure because you've either have plaque shift or dissections, and then you end up requiring stenting and compromising flow in that vessel. But also outcomes. Bifurcations have higher incidence of restenosis, leading to higher adverse events and periprocedural complications, but including acute and late stent thrombosis. So these are the two challenges that as a community we need to treat. We also have to be cognizant that about 20% of all PCIs do entail some kind of bifurcation or another. And we do want to maintain the integrity of the native anatomy. Now, we all know the point, the point of confluence, we know the fractal laws, and we want to maintain that because our understanding is when we do that, we reduce event rates. And particularly so in complex but true bifurcations, the evidence suggests that an a priori double stent technique or a two stents technique improves clinical outcomes compared with provisional strategy alone. And again, as I mentioned, in modern day PCIs, where we have all these technologies in the cath lab, imaging, atherectomy, et cetera, our aim and our purpose is to reduce major events. Now, important trials like the EBC main, EBC2, DK crush, these are all randomized trials that noted that a second stent is necessary in about 20% of cases, and a stepwise strategy is right now recommended per the guidelines. But this is what I was talking to you about moments ago, is kind of understanding the anatomy of what we're dealing with. We're talking about the main vessel, the distal main vessel, the assigned side branch, but we're also looking at the point of the bifurcation itself. We have to understand when we're talking about the angle, which angle, so that we're all speaking the same language. And ultimately, we want to look at the polygon of confluence, which really determines the hemodynamics of what's happening. Modern day cath labs with enhanced imaging, et cetera, will help us define it. It's very important that we're able to get an angle that actually opens up that bifurcation well and permits us to define the different parts of the bifurcation. The Definition 2 trial actually put some standardization for us to look at the major criteria and minor criteria for left main and non-left main bifurcations. So for left main, you're looking at a major criterion, side branch more than 10 millimeters in length and more than 70% diameter stenosis. And for non-left main, again, 10 millimeters in diameter stenosis of more than 90. And then the minor criteria, as you can see over here, multiple lesions, thrombus, long lesions, etc., and a bifurcation angle less than 45 or more than 70. And you have to understand the different techniques that we currently have. And you want to know that if you start with a provisional strategy, we don't just go in and say, okay, let's wing it. When I'm there, I'm going to decide what my plan B is. So even with a provisional strategy, you want to be prepared that if I do need a second stent, what is my strategy going to be for the second stent? And generally speaking, when you have a side branch and a main vessel that are similar in size, generally a culotte is suitable, wide-angled bifurcations, tap or T technique. And remember that a DK crush is generally not a bailout technique. It's something that you're going to start with as an upfront technique. So this is, again, going back to what I was telling you. There are different ways to define the bifurcation and determine whether it's true or not. The most commonly used in multiple trials is the Medina classification, 111, 101, 011, and again, trying to apply the definition criteria for that. There's the resolved scores and so on. But just remember that now we just came out of a session talking about the role of intracoronary imaging, and it has been upgraded in the ESC guidelines to a 1A classification for bifurcations. And then coronary CT, I know many still do not use coronary CTs routinely to strategize and plan. Nevertheless, it may be something quite futuristic, but again, it helps you define very similar parameters and maybe even quantify the burden of plaque in your side branch and define your angle well before you come in and you go in, knowing what size you're going to use, so the virtual planning really, and you know the size of the stent and the balloons and where you're going to start and where you're going to end non-invasively as opposed to the invasive imaging. This is a technique that's called the inverted culotte technique. Many of you have seen some live cases where we're wiring both vessels naturally. We're stenting the side branch. After we position the side branch, stent and dilate it, we usually keep the wire to maintain access. We do proximal optimization to make sure we get adequate scaffolding and rewire appropriately, and then we do our kissing inflation, which is usually sequential simultaneous kissing. Deliver your stent into the side branch and look at that overlap segment. You want to rewire, do your second proximal optimization to make sure that in your main vessel you have adequate apposition of that stent and expansion, of course, and then you do probably a final proximal optimization. You do not want your balloon expanding well beyond that stent, and then this is probably what your final result looks like. And this is sort of a fly-through into it. So I'll just take you back a decade ago, and gosh, this makes me feel old. We wrote this in 2019, Dr. Shabi, if you remember. This was the commentary on the Triton study, the 5-year outcome. But bear in mind that Triton was a very different technology. It was actually thicker struts, and it was technically a bare metal stent at the end of the day at your carina. So the Biomem branch stent really is different. It's much thinner. It's 65 microns. Technically, it is a drug-eluting stent. You do deploy it in your side branch back into the main vessel. Interestingly, and you do see that our vessels do tend to taper, right? Importantly to note that there are markers that allow you fluoroscopically to see where you are, find out where your carina is, where your connectors are. So you're positioning your carina marker and then the distal one where your side branch marker is, and it helps you, guide you when you're trying to rewire and do your inflations and so on. So again, remember, this is technically a sirolimus-eluting stent. It is thinner than what we were used to, and over the course of a decade, a lot has certainly changed. This is another angiographic, animation that pretty much tells you the same steps of what we were talking about, where you want to make sure you do your pre-dilatation that is appropriate. Again, always wire both vessels, deploy the stent across the bifurcation segment. You see how that area, you have open cell struts that facilitate really recrossing, but you do want to do your post-dilatation. You are going to come back and do your Step 4, prepare the main vessel. You're recrossing, as you can see. And again, you're trying to go to a non-proximal, so a more distal recross. You can do your kissing inflations if you want to do a first kiss, and then bring in your stent so that you're really doing a 2-stent layered technique. And it's pretty much a culotte similar to what I had just showed you in the previous animation. But this is with them. And you see that with those open struts, it's a lot easier to recross. So these are the steps all over again. I'm not going to belabor it so that we have time for discussion later. But really, the design conforms to the lumen geometry. You just saw that. It's the way that the struts are thinner and open, exactly where you want them. They pinpoint and they allow you to identify. I mean, let's get real. You really cannot tell where you are. It does simplify the procedure, and it allows appropriate. I'm trying, for the sake of time, I am trying to skip, but this is ultimately, as an operator, what we want. We want optimal main vessel and side branch coverage and scaffolding. We want to make sure we are protecting that side branch so that we do not lose it. And we do want to have limiting the layers that we have in the main vessel. So again, this is to just show you that you actually can see the markers very nicely, where you're seeing the side branch osteal marker, the distal marker, the carina marker, and it helps you angiographically to decide what you're doing and where you're doing it. Again, kissing inflation, you just familiarize yourself with these markers and you act accordingly. The trials, this is a small-scale trial that was actually published from an Italian group. It's really the first clinical experience. They do have 18 months worth of data that they published, but it was a small series of about 60 patients or so. Primarily men, age was about 69 years old. CCS was about 84% of the patients, but nevertheless about 15% were acute coronary syndromes. So you do know that there is room for us to still explore and study this stent. But really, when you're looking at the different side branch, looking at the bifurcations that they treated, they did treat left mains and LADs and right coronaries, and they did look at outcomes that were hard endpoints, such as cardiac death, spontaneous MI, stent thrombosis, etc. Unfortunately, at 18 months, albeit a small series, the results were actually very promising. Again, this is one of the examples that you can find in the published article itself, and it actually walks you through it, and you see the exact same thing that I just showed you moments ago, and you see the CT planning and so on for it. But I do think this is something with potential for the future, and we're certainly going to need something. I started my presentation talking to you about using imaging. This is, again, from that same publication. You're looking at the side branch, that's your first image. You look at your carina, that's the central image, and you're seeing that beautiful 8 figure that's showing you a well-expanded stents in both the main vessel and the side branch with no deformation, and you're restoring the anatomy that we want, and then your proximal main vessel, a well-expanded stent. So I think overall it is promising. I would like to see larger randomized data on this stent, but I think we've come a long way since the Triton for sure.
Okay. Thank you very much. I think I can't resist. I have Goran Stankovic here, so I have to ask his opinion on dedicated bifurcation stent. The one we just saw now starts by stenting the side branch. So essentially goes a little bit against the EBC mantra of keep it simple, provisional, stepwise, because here you're starting with the side branch. So how do you view this field of dedicated side branch stenting progressing?
Yeah.
Do you see a future?
Thank you for that question. First, it's a dogma that we are against 2 stents. We just believe that provisional stepwise strategy can be used also if you plan 2 stents upfront, and this is excellent solution for inverted culotte, because inverted culotte is actually provisional towards the side branch, then provisional in the main branch. And I believe by enhancing the steps and rewiring, this offers potential. Limitations of the Triton were actually poor selection of patients, and 2 small side branches were actually included, plus it was bare metal platform. So before showing the benefit, they actually failed just because of maybe not being with the time and DES development as the other trials did. So failure of Triton was mainly conceptual, not the failure of the device per se.
Great, and I think with that, we'll move on to our next speaker, Dr. Samih Lawand from Riyadh. Long diffuse lesions need long tapered stenting solution. Dr. Lawand.
Assalamu alaikum. As you know, coronary artery disease is becoming more and more diffuse, more and more prevalent. Long lesions require more than one stent with overlapping segments, multiple stents deployed in tandem, resulting in overlapped segments, and these can carry inflammatory responses, poor healing responses, etc. So there are limitations as to where and how to put stents at edge to edge or slightly overlapping and sometimes more overlapping. All of this can pose to us some stresses or some what you call untoward adverse events. So majority of restenosis can actually occur at these segments. Not only that, the discrepancy in size of the vessels have also been challenging us, where for at least 20 millimeter of any vessel length, we may lose 0.5 millimeter of the diameter, and this tapering effect will result also in challenges in making balloon sizing. So long lesions with reference vessel diameter mismatch, multiple stenting, increasing contrast media needed for every stent you have to re-inject again and again, avoid overlapping, reduce total procedure time, and of course we need to consider economical changes. These long tapered stents have all acceptable or well-used sizes, anywhere from the proximal 3.5 down to 2.7, and ending at the distal edge with a 3 down to 2.25 in diameter. It's an open. It's a hybrid cell design, cobalt chromium. It's unique in strut width and variability, special electropolishing, and stent is mounted on a flexible balloon. And you see here the lesions before, the lesion after, straightforward, no issues, and no discrepancy at the distal edge. In this real-world experience that was done at Bahrain, 120 cases were done, the 12-month outcome was very satisfactory with that confirmed these results. And in this long-term safety performance by my MORPH serum-eluting stent study, also followed at 3 years, showed extremely low MACE and 0 stent thrombosis. And this shows you the runoff, the follow-up of these patients with 8% MACE at towards 3 years. I'm presenting this case, a 69-year-old male presented with acute coronary syndrome, non-diabetic for long years, hypertensive, dyslipidemic, admitted for stabilization and to be followed by coronary angio and possible PCI. His left system, you can tell the LAD, you would think it's open. Actually, it's a recanalized total occlusion, and the circ, you can see it's at least moderately diseased at the middle third. And if you look at the right coronary artery, you would think this is a very rugged terrain with a lot of calcifications, and chances are you have to prepare yourself for some problems. So I elected to start with the right coronary. I always like to start with the more difficult situations, and I started pre-dilating. Of course, initially I had difficulty advancing balloons, but it went anyway, and then continued to increase the size of my balloons in order to allow for ability to advance a stent. And here we are. I tried my first very long stent, 60 millimeters, 3 millimeter, approximately 2.75 distally, and in the middle of the vessel, I got stuck here. So here we are. I have to face another issue. So I decided to redilate again. This time I used a scoring balloon repeatedly, and slightly larger sizes, and then tried again. And again, I could not. Of course, I needed a good supporting guiding catheter, well positioning of my wire, etc. All of these are required. And again, a third attempt, also I'm facing trouble. Now, this time I used double wiring and still did not work. Eventually, after this particular ballooning, I managed to advance it and positioned it proximally in order to cover all the entire disease segment. And here we are repositioning and deployed. And post-dilatation, 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 etc., post-dilatation.
Yeah.
Now then I went to the distal RP-LV branch where the segment was and dilated it repeatedly. And using a guide liner, I ended up advancing my drug-eluting balloon all the way to the RP-LV branch and finally deployed, and very good result. The distal RCA to me appeared maybe not significant. I magnified the image and it turned out to be less than 40%. I left it alone. And this is the final result. Then I did his left circumflex with a pre-dilatation as usual, and eventually, repeatedly, until I got a better result, and then advanced my drug-eluting balloon without stenting with good result. And here we are facing the LAD, totally occluded with minimal flow, and started escalating my wires all the way up to the Asahi wires, all the way to the maximum. And eventually, after I managed to also wire the diagonal, eventually managed. And then I pre-dilated the proximal segments and stented, and this is the final result. You will see the final result here. Okay, patient really had a very uneventful post-procedural course. Patient received usual anti-ischemic, anti-thrombotic treatments. Prasugrel was my choice, and along with aspirin. Of course, high-potency statin, antihypertensive, antidiabetics, and patient upon follow-up remained well. About 1.5 years later, patient presented with atypical symptoms. I did his nuclear stress test, and it was normal. For long diffuse lesions, as you know, in order to give you my take-home message, single long tapered stents potentially minimizes the risk of fracture, binary stenosis, and associated adverse events. Branching coronary arteries tend to taper, and anatomically designed tapered stents may provide better stent conformability without altering the vessel anatomy. Long tapered stents are convenient from a procedural perspective and allows for optimizing procedural cost and patient outcome. Thank you.
Thank you very much. Thank you. You made it very clear that this is potentially really useful. Dr. Meril, I think you practice in Iran, right? How important would it be to have a stent like that for everyday practice?
I've used taper stent in some cases, as you mentioned. For example, when we have great discrepancy between proximal and distal main vessel, we can use taper stents. It's a very good idea, as our colleague said, for prevent from binary stenosis, edge dissection, and some, for example, discrepancy in distal vessel.
Excellent. I think with that we close. Thank you very much. And the final speaker, our good friend Ashok Seth, will update us on the Myval THV.
Thank you very much. Great innovations, and certainly now we're changing track a bit. My conflict would be that I was the first in-human study investigator for some of those devices for its approval in our country. And then again, here's another one for which I was the principal investigator for the first in-human study. And this, I come to my potential conflicts, which I've already stated. So we're going to talk about the Myval, a novel valve, which is a balloon expandable transcatheter heart valve. The design philosophy, of course, you're getting used to this valve by now. It's a nickel cobalt alloy frame with a high radial strength with anti-calcium treatment of bovine pericardium trileaflet. It's a trileaflet valve, of course. Approximately 50% distribution, closed cells, three rows of closed cells at the bottom with an upper layer of large hexagonal honeycomb cells. Now, there's enough experience around the Myval. The real-world clinical experience now goes around to 20,000 implants globally across 80-plus countries. More than 4,000 patients have been involved in clinical studies with more than 90-plus publications. And it has had consistent performance across numerous clinical indications and high-risk surgical categories. And of course, regularly used for bicuspid aortic valves, pure aortic regurgitations, valve-in-valve interventions, extra-large aortic valves, tricuspid valve, ring-in-rings, pulmonary valve, commercial alignment, of course, is popular, and valve and MAC as well. We now have, of course, the results of the latest randomized trials available to us. A bit more about this transcatheter heart valve. Myval is directly mounted on a navigator delivery system. It has 2 stoppers. It is just like a stent. There is no sheath covering it. These 2 stoppers create a snug fit of the valve in it. The balloon, of course, is this delivery system is highly flexible and can be maneuvered across the aortic arch by its flexible rotator knob. It has a unique fluoroscopic appearance when mounted and crimped on this balloon. It creates these closed cells, create these dense bands, and of course there's an open cells which is high up. These dense bands serve as a marker for precise implantation. We use the second dense band as the marker for annular plane, as will be seen in this illustration. Here is the situation where this valve is put. This is the second dense marker band we use. That enables a 70-30 implantation with 70% in the outflow tract. And after implantation, this valve would end up as 90-10 or 85-15, which is the shallow implant that we need for best outcomes. Here's this again showing this implant. The lower end of the pigtail is at the second marker band. The valve gets implanted. It is at 70-30 position, as you would see, implanted nicely. You would see that in the next frame. Sorry, this should have moved on the right side, and there it is. A 90-10 implantation, a good shallow implantation with best outcomes. The introducer sheath, this is the valve which is introduced into the introducer sheath. The introducer sheath is a 14 French lubricious, takes all sizes of valves from 21.5, or from 20 millimeters up to 32 millimeters. So of course, it's an extremely useful sheath for that purpose, but the biggest advantage I would see is the retrievability of the valve through the sheath itself. And this is well nicely demonstrated in a case where the valve has not been able to cross a bicuspid case, which occasionally happens to us when the valve has not been prepared, the native valve has not been prepared well. And here it is demonstrating that you can bring this valve back, unlike the other self-expandable valve, can bring it back through the sheath. Now, work at the native valve again with pre-dilatations and get the valve back in. It's available from 20 millimeters up to 32 millimeters in diameter, with quarter sizes, with half sizes or intermediate sizes, as we call it, and available for areas of close to from 270 to not just 840. The 32 valve can treat up to greater than 900 millimeter square areas. Now, here's a very illustrative case which exemplifies the value of intermediate sizing. 26.7 millimeter annulus diameter, which would traditionally be for a 29 millimeter transcatheter heart valve. And that would be a 17% oversize or a more than 18% oversize. But then we have heavy calcium burden, we have protruding calcium from the outflow into the outflow tract, as can be seen here. And 17.7% on a 29 millimeter valve would be at a risk of annular rupture or complications. And a 27.5 millimeter valve, the intermediate sizing, which is only available with Myval, is a 6% oversize, which is optimal for this geometry. And therefore, we need to respect anatomy, and we need to tailor our valves to the anatomy, and the geometry of the valve matters. Close to 50% of the valves used in the real world, or my valves used in the real world, and in the clinical trials, have been the intermediate sizes. So we have real-world feedback now. The follow-up, especially from our first in-human study, crosses 6 years. And has it maintained its durability? Soon you'll see data on the first in-human study and the first implants of the Myval, which has been collated, a multi-center collation of that registry for a long-term follow-up. But here is this use of this valve in multiple anatomies, in practically most of the scenarios where a balloon expandable valve could be useful. And that goes for pulmonic, that goes for tricuspid, and that goes for MAC and MAC as well, because obviously what is important for valve in MAC is this extra large size. The extra annulus, of course, goes up to 840, but annulus sizes of greater than 900 can be treated. And I want to emphasize that in the studies at the moment in evaluation is a 35 millimeter valve as well. These valves, the 32 millimeter valve is compatible with a 14 French sheath, and as you know, the need is there. 10% of the valves that are used are in 32 millimeter valves. So these large anatomies are not unusual, especially across the world. And here's one such scenario. An area of 931, diameter 34 millimeters, 32 millimeter Myval with plus 5 cc's gets absolutely a perfect result with an implant which would be clearly 90-10, no paravalvular leak, no gradients, and no need for a permanent pacemaker implantation. I call it not just ground zero, I call it 4 zeros. Yes, and here's another one. Here's another case of two valves, two evolute R, an evolute R for a patient with severe aortic, this patient had severe aortic stenosis, an evolute R, 34 millimeters implanted, valve degenerates, severe AR, a 29 millimeter evolute gets implanted. Inside the 34, the patient gets readmitted because there's a remainder paravalvular leak, and then he's admitted with heart failure in AR, and a 32 millimeter valve gets implanted, a Myval gets implanted with excellent result and no aortic regurgitation, PVL. So this slide outlines what I've said. It is a normal transcatheter heart valve, the Myval, with unique features which you've seen and have been outlined quite much here. Of course, let's get to the clinical update here. What's the evidence? In the landmark study, the pivotal randomized study of Myvalve on 768 patients enrolled at 31 clinical sites in 16 countries, Myvalve met the non-inferiority endpoint at 30 days versus the contemporary transcatheter heart valves, which was the Sapien series and the Evolute series. And those are the results which were published in Lancet, presented at the PCR and published in Lancet. And of course, what struck out to me most in this study was I was confident about the non-inferiority at 30 days. But what struck out most was what I hadn't expected. Effective orifice areas of Myvalve were larger than those achieved by the Sapien valve. And in the larger valves, clearly, it was as large as the supraannular Evolute platform. What did that mean for us? That meant that for once we had a balloon expandable valve, which gave us a least patient processes mismatch and had effective orifice areas larger than or equivalent or nearly the same as supraannular valves, and that I may say, the long-term data of Landmark is going to be very interesting as it goes on to a 10-year follow-up over a period of time, as it may affect or decrease valve degeneration and enhance durability. So that's for us to see. Of course, the predefined statistically powered subset analysis of this has been published of Myval versus Sapien from the Landmark study and Myval versus Evolute from the Myval study, and has been found to be non-inferior to the Sapien at 30 days. Of course, at the London Valves was presented the COMPARE-TAVI, the largest single randomized trial on the two balloon expandable valves, Myval as well as the Sapien, with a 1-year follow-up. And that again demonstrated a non-inferiority of Myval transcatheter heart valve series at 13.8 to the Sapien series. And this was as per VAC-defined criteria and all the endpoints, and were as per VAC-defined criteria. A commissural alignment is a novel methodology possible with this valve, and the octa-align technique achieves commissural alignment in more than 80% of the cases. I won't go through in detail about that, but that's been well documented and defined and published, and it's easy to practice and therefore is replicable. Where are we going from here? Moving on, it says Myval has now moved to the octacore design, which is octagonal, 2 rows of octagonal cells. This decreases the foreshortening to 20%. It's a valve which was used in the COMPARE TAVI study, and 70% of these patients had octacore Myval. And of course, moving ahead to the design concept of minimal foreshortening and precise and predictable deployment is this 2 low rows of now, and what you see here is rhombuses, but in this, the chevrons have now been inverted. And this, therefore, retains the legacy features of Myval, but decreases the shortening to 10% and 12% for the large sizes. And this is well demonstrated in this ex vivo study. And you can see there's practically no shortening. And just to get you to a single live case, the first introduction into India of this is a 77-year-old gentleman with severe aortic stenosis, 25% ejection fraction, renal dysfunction, was in pulmonary edema a week earlier to this, was decongested, has a bicuspid aortic valve type 0, and what he requires is a 26 millimeter. This is the OctaPro, 7% oversizing. Look at the precise deployment of this valve, placed at 8510, and that is all that valve does. Here it goes up. This is the deployment. You can see that EDP is raised of this gentleman. There was no contrast used, a single deployment, and that is where it lands. And what it demonstrates is a 90-10 implantate, and precisely where we left it is where the valve stays. And this is what I call 4 zeros: 0 implantation, 0 PVL, 0 gradients, and 0 conduction defects. So I think I'd say that the key takeaways are that this series is a predictable, precise deployment with minimal foreshortening. The octa-align technique allows for commissural alignment in a predictable and easy manner, and the Myval transcatheter heart valve series represents a novel and an important step forward in achieving the goals of lifetime management of the TAVI patients. And of course, what a memorable journey it has been since I first presented the first in-human studies at the PCR in 2018. And in 6 years, we've got to the present status. Thank you very much.
Thank you, Dr. Seth. And with this, we come to the end of this session. I'd like to thank Meril Life for sponsoring this session, to thank all our speakers for wonderful presentations. Have given a glimpse of what's coming from Meril Life, whether in the coronary field or in the transcatheter heart field. So thank you all very much.